Good evening, everyone. This is Sri Priya, welcoming you to our 13th session of Foundation course in Palliative Medicine. Today, as promised earlier, we have a detailed session on wound management, and we have the very apt person joining us for walking us through the session, Sister Sheeba. It is my personal privilege and honor to have her with us today. Sister Sheeba is basically a staff nurse having 18 years of professional experience and presently heading the clinical training department at Pallium India. She is a certified trainer at the NHSRC, the National Health System Resource Center, and she was recognized as the pioneer nurse in the year 2020 by St. Christopher Hospice, the world's first hospice in UK. So it is indeed my pleasure welcoming her to this session. Sheeba ma'am, over to you.
Thank you for the kind introduction. Good evening all. Happy to see you all. As Sri Priya said, today we are going to learn about wound management. So you might have seen different types of wounds in your settings, but in palliative care, we have seen two different types of wounds. One is pressure ulcer and the another one is fungating wound or a cancer wound. So let's see what is pressure ulcer, what are the causes, what are the risk factors. So what are the stages of pressure ulcer, how we can manage pressure ulcer and how we will prevent pressure ulcer. So then we will see how to, what is fungating wound and what are the causes and what are the pathophysiology and how will be managed. So let me share my screen. Hope you are able to see my screen. So as I said earlier, we have seen two different types of wounds. One is pressure ulcer and another one is fungating wound. So let's see what is pressure ulcer. So there are three major causes of pressure ulcer. One is friction. The second one is continuous pressure. The third one is moisture. So unrelieved pressure, moisture, friction. These are the three major causes of pressure ulcer. So let's see what is pressure ulcer. Pressure ulcer is a localized injury to the skin and other underlying tissue, usually or a bony prominence as a result of prolonged unrelieved pressure. So if there is an prolonged unrelieved pressure there is a chance of getting pressure ulcer on the bony prominence, especially on the bony prominence, but it can occur anywhere. Okay, so you have seen that picture also. It's not only on the pressure areas, it can occur anywhere. So based on the patient's position, depends on the patient's position, it can occur. So let's see what is the pathophysiology of pressure ulcer. You can see that picture on when a patient lying on a bed, usually supine, the patient is usually lying down in supine position. When a patient lying down in supine position, what happened? Their body weight are compressing, the bone weights are compressing the tissues. Then the tissues may not get adequate blood supply. So you can see that if there is a prolonged unrelieved pressure there, so that leads to that because of the body and body weight can cause the compression into the tissues happen. If there is a compression there, the tissues may not get adequate blood supply. If there is a collapse of blood vessels there, what happened? The tissues may not get nutrition, oxygen and all. Then finally tissue ischemia, stress and breakdown. So this is the pathophysiology of pressure ulcer. Why I am telling this pathophysiology is, so whenever we see a patient, in a bed-bound patient, you have to keep it in mind and empower the patient and educate the caregivers about the turning techniques. So we need to change the position every 2 to 3 hourly. Okay, so we need to give a proper good idea about how to develop pressure ulcer. Then only they will follow your instructions. So coming to the risk factors, there are a lot of risk factors. The first and most risk factor is friction and shear. So this is the most common risk factors because friction. Usually for a bed-bound patient, we need to change the bed sheets. Okay, we nurses know how to change a bed sheet for a bed-bound patient, but the caregivers doesn't know. They need to change the sheets, but they don't know how to change the sheets. They usually what they will do, they pull the sheets under the patient. So if they pull the sheets under the patient, what happens? There is a chance of friction between the sheets and the skin. So there is a chance of breakdown. If you apply more pressure on that same pressure on that area, definitely the pressure so will come. Then the second thing is shear. So when an obese patient is lying on a bed, usually they slipping downwards. So when we try to reback to their normal position, what happened? So we used to apply more pressure on that body. So our idea is to lifting up the patient, the head, and we need to that move the patient from the lower bed to higher level. So that time there is a chance of injury to the tissue, the teeth tissue injury happen. So whenever we change, we shift the patient, we lift the patient from the lower part to upper part, we need to lift the patient with the of a sheet, not pull the patient up. Then impaired sensory perception and impaired physical mobility. So for a paraplegic patients, they may not sense the lower part of the body. So that patients may get pressure ulcer easily and impaired physical mobility. That for a bedbound patient, they are not able to move independently. So they need a help. For a paraplegic patient also, they need to turn, but they can't. So they need a help to turn. So these are the other risk factors. Then altered level of consciousness, either semi-conscious or unconscious patients can get pressure ulcer. Then fecal and urinary incontinence. So as I said earlier, there are the third major cause of pressure ulcer is moisture. If there is a fecal and urinary incontinence there is a chance of getting moisture always. So if there is a moisture there, again the patients will get pressure ulcer. Then malnutrition and dehydration. If you don't give that, if the patient is not taking adequate protein intake in their diet, again that patients can develop pressure ulcer. So the diet is also important for preventing pressure ulcer. Again, dehydration. If there is dehydration there is no blood volume. Again, the tissues may not get adequate blood supply. Again, the skin integrity will be reduced. Then the patient will get pressure ulcer. Last, excessive body heat and advanced age. These are the major risk factors of pressure ulcer formation. Coming to the common sites, these are the common sites. It can occur anywhere. So you can imagine supine position, sideline position. You can see that picture. Fowler's position. Even if the patient is in wheelchair, also that patient can get pressure ulcer. It can occur, especially on the bony prominence, but it can occur anywhere. So you can see that picture. You understand that it can occur anywhere: heel, occiput, scapula, toes, sacrum. So all that areas will be affecting. So it depends on the patient's position, it can occur. So coming to the supine position, they are the red spotted areas. These are the major pressure point areas when the patient is lying in supine position: occiput, elbow, sacral region, heels, and scapula, toes. So these are the important areas that patients can get pressure ulcer in the supine position. So why I am telling these all points is, so whenever we turn the patient from supine to sideline position, you have to give special attention on that area. Okay, if whether there is any color change, any breakdown, these all things you have to look into. Then coming to the sideline position, if the patient is on sideline position, ear acromion process, drips, greater trochanter, so you can see that areas. So whenever the patient is on lying right lateral or left lateral position, you have to keep a pillow or a soft, the small pillow or a soft, the cotton folded sheets in between the knee knee, because there is a chance of the knees are the rubbing together. Again, that friction can cause pressure ulcer. So always you have to keep a soft pillow or a folded sheets in between the knees when the patient is lying the side lying or the left lateral position or a right lateral position. So coming to the Fowler's position, this is the good position for relieving dyspnea. But even if the patient is on Fowler's position also, we need to turn at least to 10 degree. 10-degree pressure relief is mandatory, because you know no need to the patient is turned supine. We can say keep the same position, but you can turn at least to 10 degree. And coming to the prone position, here head, elbows, chest, reproductive organs, knees and toes are the important major points. Here, if the patient is having the huge pressure ulcer on the sacral area, we keep the patients this position for some time, then either right lateral or left lateral position. So even if the patient is on prone position also, the patients can get pressure ulcer on those areas. So we need to give a special attention on that areas. Coming to the stages of wound. So there are 5 stages of wound. The first one is non-blanchable erythema. So this is the stage 1 pressure ulcer. Okay. So here, if you turn the patients from supine position to side lateral position, if you see this type of color change there, you can apply your finger pressure on that area. If you apply when you apply finger pressure on that area, that redness is not blanching. Okay, so that usually that color is blanching if there is a normal tissue there. If there is a stage 1 pressure ulcer there, when you apply pressure on that area, there is not blanching. That is called non-blanchable erythema. Okay, so this is the stage 1 pressure ulcer. Then we can move on to the second stage pressure ulcer, that is shallow open ulcer. It can damage the dermis layer. Okay, so here, the dermis layer will be breakdown, or the blister formation will be there. So if there is a blister formation there, definitely the blister will be burst and definitely the skin will be exposed. So this is the second stage of pressure ulcer. Coming to the third stage, full thickness ulcer, that means all subcutaneous tissues will be affecting. So if sometimes the tunneling will be there. The tunneling means a narrow opening or a passageway that can extend into any directions through soft tissue. If the patient's wound is having tunneling, you have to give a special attention to that area. Otherwise, that wound won't be healed properly. So you, whenever you do the assessment, you have to do the proper assessment. Then only we can able to find out whether the wound is having tunneling or not. So coming to the fourth stage, exposed bone, muscle and tendon. So this is the fourth stage. Okay. The fifth stage is unstageable. If there is a slough or a black necrotic tissue on the top of the wound, we can't assess the stage. That is, we call it as unstageable wound. When we document it, you have to document it is an unstageable wound. Once we remove the slough or the necrotic tissue from the top of the wound, then only we can able to find out whether the wound is affecting that extending to the subcutaneous tissue or muscle layer. All things you have to find out. So when if you see this type of wound, after that you can document it is an unstageable wound. So there are 5 stages of wound. The first stage is non-blanchable erythema. The second the stage is the dermis layer will be breakdown. The third stage is full thickness ulcer. That means subcutaneous tissues will be affecting. The fourth stage is muscle, bone, tendon will be affecting. The fifth one is unstageable. Okay. These are the 5 stages of pressure ulcer. So coming to the assessment part, either doctors or nurses, you have to, whenever you see a bedbound patient or a wheelchair patient, you have to assess the pressure areas. or if the patient is having wound, you have to check. You have to assess properly whether the wound size, wound that the patient is having any pain. So you have to talk to them. We don't know pain. We understand that pain is a subjective experience, and we need to believe the patient words. We need to ask the patient whether they have pain or not. So you have to ask them whether they have pain or not. If they have pain, you have to give some analgesics for that and wait for some time, and then you can do the wound management. Then assess location, measure width, length, and depth of the wound, stages of pressure ulcer, and presence of exudate. Exudate means purulent discharge from the wound. So any pus discharge or a clear, maybe clean that water oozing of that fluid like contents from the wound, that is called exudate. So you have to assess for that. Then assess for tunneling. All these things you have to document it properly so that we can able to compare that wound from the after 2 weeks. You can do a then again you can do the follow-up with the patient, and then you can do the assessment. Then you can able to compare whether the wound is better or not. And also, if you document it properly, your that colleagues also get good idea about the patient care and the patient own condition. Coming to the management part, as I said earlier, always medicate patient for pain before wound care. So this is very, very important. They are helpless. If the patient is having wound, they won't tell anything. They will be calm and quiet. So because they have a that wound. So whenever you go for a home that wound care, they will be calm only. So when if you ask whether they have pain, definitely they will tell you, yes, I am having pain. So I am having a 6 out of 10 pain. So if they have pain, you have to give proper analgesics for that. Then you can do the pain wound dressings. Okay. Coming to the stage 1 management, if there is a stage 1 there, that means non-blanchable erythema, it's a red color skin there, that is stage 1. You can talk to the caregivers. You can teach the caregivers about the incontinence control and turning techniques. You have to prevent further pressure on that area. If you keep the patient in the same position, definitely the skin will break down. So the first stage management is to prevent further pressure on that area. If there is a non-blanchable erythema there, you have to prevent that pressure on that area. Coming to the stage 2 pressure ulcer, there is only clean wound, no slough. You can clean with normal saline. Okay, your normal saline is enough for that second stage wound management. Coming to the third, fourth, and unstageable management, if there is a stuff there, that means black necrotic tissues there, you have to do the surgical debridement. Okay, so use normal saline for wound cleaning, and also you can teach how to prepare homemade saline also. Okay, when the patient is in the hospital, we have normal saline bottle. We have nurses. Our nurses will take care of that wound. So when they go back, so who will give normal saline? Who will take care of the wound? So when the patient is in the hospital, you have to give a proper instruction and demonstration about the home care and empower the patients about wound care, and teach how to make homemade saline and dressing materials. I'll teach you later on how to prepare homemade saline and homemade dressings. Then coming to the order or infection, if there is an infection there, you can give metronidazole powder. That means you can take metronidazole tablet and crush it, make it a powdered form, and mix with white petroleum jelly and paste, make it a paste form, and then apply on the wound. So if you apply like this, the wound will get two effects. One is that metronidazole will reduce the infection, and white petroleum jelly will give a moisturizing effect to the wound. So if the patient is having that black necrotic tissue or a water or infection there, you can apply metronidazole, that powder. And also you can suggest Debridex ointment and Megahil. If there is a stub there, Debridex ointment is the good medication, but the thing is too expensive. If the patient is affordable, you can suggest for the same. And after removing the slough, you can apply Megahil ointment. So Megahil ointment also help to improve the granulation tissues. So if there is a malodor, like if there is a fourth stage pressure ulcer there, definitely there will be a malodor there, will be there. So if there is a malodor there, charcoal dressings, you can apply charcoal dressings. Charcoal is the good agent for absorbing bad smell. But the thing is, charcoal dressings are available, but the thing is too expensive. If they are not affordable, you can suggest charcoal pieces, that you can take 1 or 2 pieces of charcoal piece and keep under the bed of the patient or keep it under in the corner of the room. That will help to absorb the bad smell. And here, avoid hypochlorite solutions like powder iodine and hydrogen peroxide. We are not encourage the patient to use hydrogen peroxide or powder iodine to the wound. So this will that destroy the granulation tissues. So we usually suggest normal saline. Normal saline is the good the solution for cleaning the wound. Normal saline is enough for cleaning the wound. Sometimes surgeons post-operative, if the patient is doing that preparing for a skin grafting procedure, surgeon will suggest powder iodine, clean with powder iodine solution. So if the surgeon suggests clean with powder iodine solution, we diluted the powder iodine solution and clean with powder iodine solution. Then again we clean it normal saline. Usually we clean with normal saline. And then you can refer the patient for surgery consultation also. If the patient is having the fourth stage pressure ulcer, but the patient, the health status is okay, then you can refer the patient for surgery consultation, and you can see whether there is any chance of skin grafting is possible or not. If they are able to do the skin grafting, you can arrange for that. You can maybe you can do help the patient to do the skin grafting procedure. And the last the treatment option is negative pressure wound therapy. So here this is also good for wound healing. If you give a negative pressure wound therapy to the wound, that will help to reduce the blood that exudate from the wound, and give a continuous pressure can cause that improve the, because of the stimulation, and cause good granulation tissues will be coming up. So this is the good option. With the help of a suction apparatus, we can do it. So coming to the homemade saline and dressings preparations. So usually in palliative care settings, providing this dressing materials and that dressing materials, but if they finish, that dressing materials finish, how will they do the dressings? Always you have to teach some home remedies to the caregivers about how to prepare that dressing materials in their home. So let's see how to prepare homemade saline in their home. So take 500 ml of water and add 1 teaspoon of salt. Then they can boil it, cool it. So that solution they can use for cleaning the wound. Here, this is not a sterile wound. Wounds are wounds are clean. So clean saline is enough for wound cleaning. So, and if the dressing materials are finished, they can take cotton sarees or dhotis, cut into the square pieces, then steam it. So half to 1 hour they can steam it. Then they can take it for the dressings. Before touching the sterilized dressing materials, you have to instruct the caregivers about the wash their hands with soap and water thoroughly. So we all know that prevention is better than cure. So here also, whenever we see a bedbound patients, you have to educate the caregivers about how to prevent pressure ulcer and patient also. So let's see what are the things we need to look into. The first one is position change. Every 2 to 3 hours, you have to turn the patient. So then only we can able to relieve the pressure on that pressure, that position. And every 15 to 20 minutes also, if the patient is on wheelchair also, they have to relieve their pressure. So at least they no need to turn. So whenever if the patient is on wheelchair, then there itself they can relieve their pressure. I'll show a video on that prevention of pressure ulcer video. Then you will get a good idea about how to relieve the pressure on the wheelchair patient. So then the second thing is manage incontinence. So moisture is one of the major cause here. You have to manage incontinence. If if the patient is having incontinence of urine there, you can you can put a Foley's catheter if the patient is willing to. So if they are not willing to put a catheter, you can advise the caregivers about the usage of diaper. If they are not affordable to use a diaper, then you can instruct the patients whenever the linen is wet, they have to change it as soon as possible. That way we can able to prevent pressure ulcer. The third one is special surface. So air mattress and water mattress. So you can see that air mattress and water mattress here. So these two mattresses are this is the thing for preventing pressure. This mattress will help to preventing pressure ulcer. Even if the patient is on air mattress or water mattress, they need to change the position. So whenever you suggest these two mattress, they might be thinking that when they put that patient, when they keep the patient is on this type of mattress, that mattress will take care of everything. So you have to give the proper instruction whether the patient is on air mattress or water mattress. They have to turn the position. This will help to prevent. It's not completely 100%. There is no evidence 100% prevents pressure ulcer. This will help to the reducing the pressure. So that important message you have to convey with the caregivers. And also you can give us pillows and cushion also whenever you turn the patients. If there is a bony prominence there, you have to give a soft pillows or a cushion under the bony prominence. So then the next thing is nutrition, hydration, and exercise. Always you have to educate the patient about, make sure that the patient is taking adequate protein intake in their diet. So if there is a lack of protein intake in their diet, can cause pressure ulcer. Hydration also you have to talk to them. And then exercise. If they are doing exercise, that way we can able to improve the circulation and we can able to prevent pressure ulcer. The last things, massage, and you can provide wrinkle-free bed and nail care. So here massage, whenever we turn the patient from supine position to the side lying position, you have to give a special attention on that pressure area. And also you can give a massage, simple massage on that area with the help of a white petroleum jelly or a coconut oil. If there is no myelin or white petroleum jelly is not there, they can use coconut oil. So massage, if you do the simple massage on that area, that will help to improve the blood circulation, and that way we can able to prevent pressure ulcer formation. Then always provide wrinkle-free bed. If there is a wrinkles in the bed, again there is a chance of pressure. So nail care also important. If there is a nails there is a chance of scratch on their own skin, and then again the peeling of skin there. If you apply pressure on that area, definitely the skin pressure sore will develop. So these are the important preventive measures. So this is one of the small. This is the small tip. SKIN. Whenever you see a patient, bed-bound patients, you can keep it in mind. SKN. This is the prevention of pressure ulcer. The first S is supporting surface. So you have to look into whether the patient is having a proper supporting surface. So you can suggest air mattress or water mattress, or if they are not affordable, you can suggest soft mattress too. The second is skin inspection. Whenever we turn the patient from a one position to the another position, you have to give a special attention on the pressure points, especially on the bony prominence. The K is keep moving. Every 2 to 3 hours, they have to change the position. And incontinence and moisture control, bladder and bowel care is important. If possible, you can catheterize, otherwise they can use diaper. And last one is N. N is nutrition and hydration. So patient must take a right diet and fluid intake. So this is the small tip for preventing pressure ulcer. So without caregivers, let's see how to engage patient and family. So this is very, very important. You can imagine a bed-bound patients, they need to change bed-bound patient in a home. The caregiver needs to turn the patient every 2 to 3 hours. So this is very, very difficult that emotionally they feel they very stressed and and also they have more that psychological they have developed more psychological impact on this, because they need to take care of the other things in the family and also take care of the bed-bound patient also. So here, without the caregiver support, we can't do anything. So we need to educate the caregivers. So, and also we need to engage the patient. So we need to educate the caregivers. How to educate the caregivers, that is very, very important. So usually we used to use the term you. So you should do like this, you should do so these all preventive techniques we usually instruct the caregivers, you should do like this, you should do like that. So instead of you have to you can start use the term we. If you use the term we, so they feel more comfortable. They feel better because someone behind them to help them. That feelings will be there. So always you can do you can start the word using we instead of you. And also you can provide patient leaflets also, that information leaflets also. If you that give a proper instruction to the patient, they may forget. So if they can able to make it like this, they can keep it there. And if they have any doubts on that, so they can look into and then they will do properly. So I'll show you a video on how to prevent pressure ulcer, then we can move on to the next part. Thank you. Okay, thank you. So I hope you'll get a good idea on how to prevent pressure ulcer. So we can move on to the next part, that is fungating wound or a cancer wound. So what is the difference between fungating wound and the cancer wound? Please share your thoughts in the chat, or you can unmute yourself and talk. So what is the major difference between pressure ulcer and the cancer wound? Anybody?
Hello. Hello,
Yes,
ma'am.
sir.
Good
Yes.
evening. I feel probably a fungating wound is an exophytic growth which probably causes skin breakdown and exposure of the underlying tissues, whereas pressure ulcer is more of a excavating wound.
Okay. Thank you, sir. Any other answers?
It's an ulcer of proliferative lesion.
Uh, any other answers?
They can be in fungating wound. It's there is underlying malignancy, but in the other the underlying tissues are normal, and the fungating wound can be very foul smelling also.
Okay, ma'am. Okay. So thank you for the contributions. So here for the major difference, okay, one more chat answer. Fungating wound is cancer overgrowth and consequent hypoxia. Cancer wound is non-healing in nature. Okay, thank you. So as one of you mentioned, the cancer wound is not preventable and not curable. The pressure sore is preventable and curable. So this is the major difference between pressure ulcer and cancer wound. So let's see what is fungating wound. So here it is a primary or secondary malignant growth in the skin which was ulcerated and difficult to heal. So once the fungating wound develops, we are not able to heal it properly. So this is the very difficult situation the patient and the family is overcome. So we need to give a total care of this patient and their family also. So here it is a malignant process involving both ulceration and proliferative growth. So day by day, the proliferative growth will be there and ulceration also. Lot of necrotic tissues will be coming out, and then lot of problems will be look into what are the physical problems, psychological problems, spiritual and social problems, and also this is a nodular fungus or a cauliflower in shape. It look like a nodulous fungus, the fungus shape. That is why we call this fungating wound, not because of fungus. So because of the that nodular fungus shape, then that is why we call it as a fungating wound or a sometimes this type of wound will look like a cauliflower in shape also. So coming to the pathophysiology, we all know that they usually develop a non-skin that skin nodules there. Gradually the skin nodules will be enlarged. If there is a nodules enlargement there is a disruption of capillaries, lymph vessels there. Gradually altered coagulation, then disorganized circulation will be there. Finally, tissue hypoxia and necrosis. So this is the pathophysiology of fungating ulcer. So coming to the Marjolin ulcer. So how many of you heard about a Marjolin ulcer, or how many of you have seen Marjolin ulcer? So what is Marjolin ulcer?
Marjolin ulcer is a malignant squamous cell carcinoma which arises from a burn wound.
Okay. Any other answers? Ulcer developed from a burn, then?
Hello.
Yes, ma'am.
Yeah, just it's an ulcer developed from the, so it's a cancer which develops from the edge of an ulcer.
Okay. Almost correct. Okay. Thank you. So Marjolin ulcer is a type of malignancy of the skin. So you can malignant changes in the chronic wound like burn scar ulcer, pressure ulcer, venous leg ulcer. So from that chronic wound like burn scar ulcer, pressure ulcer, venous leg ulcer, there is a chance of developing skin cancer. Okay. So here the pathophysiology is little bit different. So usually, previously there is no mass present, appearance of new mass in the wound. So from that mass, the patients experience pain. Concept of pain will be there, and also the change of character, volume, appearance of drainage also there. It is not previously present. So if these changes there, you can refer the patient to the oncologist and take a biopsy on that wound and find out whether the patient is developing Marjolaine ulcer or not. This is the curative possibility is high. So if they have developed Marjolaine ulcer, you can refer the patient. You can just check whether the patient is having any Marjolaine ulcer or not. So coming to the problems, as I said earlier, we have to give a total care of this patient. It's a non-healing ulcer. There are a lot of physical problems, social problems, psychological problems, and spiritual problems too. So let's see one by one what are the physical problems. So these are the physical problems. One is pain, because a direct exposure of skin can cause pain. And the second thing is the tumor will be that compressing the major blood vessels. Then the patients develop neuropathic pain. This type of wound, if the patient is having this type of wound, that patient might have developed two different types of wound, nociceptive pain and neuropathic pain. When we do the assessment, you have to assess, do the assessment properly, whether the patient is having neuropathic pain or not. So if the patient is having neuropathic pain, you have to give a proper treatment on that. And also if there is an improper dressing, if you are doing the wrong techniques, like usually the dressings are adherents to the wound. So before soaking the all dressings, if you try to remove the dressings, then the patients experience pain. So better you can soak the all dressings before removing the dressings. That way we can able to prevent pain. And malodor. So here there is a lot of anaerobic bacterial, that lot of necrotic tissue, and also anaerobic bacterial infection. This can cause malodor. And another thing is, if stale exudate dressings have been placed in number of days, is again the next cause of malodor. So we have to treat malodor properly. And bleeding. Again, if there is a head and neck cancers there is a chance of the tumor will be protruding the blood vessels, major blood vessels also. So if there is a chance there, we have to prepare the patient family about that. So how if they suddenly develop a huge bleeding in their home, so how they will manage. We have to prepare the patient family about that also. Exudate, we already learned what is exudate. There is a purulent discharge coming up from the wound. So we have to, this is the another physical problems, because of within the tissues. If there is a fungating wound there is a dilatation of blood vessels within the tumor, can cause a lot of exudates will be coming out. So we have to treat it, treat the exudate properly. And itching. Again, that exudate will be leaking out of the normal, that touching the normal tissues can cause itching. And also again the new the nodules emerge from the side portion of the wound, can cause some chemical reactions is there. Then the patient experience itching. And infestation with maggots also. Sometimes maggots formation will be there. So can anyone say how does maggots come? Any idea? Okay. So Shalim Kumar said flies. So very good answer. It come from house flies. So whenever if there is an infected wound, say there is the house flies are attracted to the wounds. If they touch the wound, they may lay eggs. Within 8 to 12 hours, the result, the maggots. So this is very, very important. We have to educate the patient about the proper dressings and cover the wound always. So they don't know yeah, maggots, how does maggots come. So we have to teach the patient and the caregivers about that. And communication difficulties. If they are, the patient is having head and neck cancers, they are not able to communicate properly. Whether that if they have a lot of physical problem or psychological problems there, they can't able to share the problems clearly. So that time, what you can do is, if they are able to write down their problems, you can give a sheet of paper and ask them to write down their problems. And then we can get a good idea about that, and then we can treat it. Otherwise, we can do that non-verbal expressions and all. Okay, so if they are not able to write down their problems, better if they are able to write down their problems, you can give a paper and ask them to write down their problems. And coming to the psychological part, again, altered body image. So imagine that huge ulcer on their cheek. Day by day, the wound is enlarging. Lot of discharge, necrotic the tissues, malodor, pain, bleeding, etc. These are the physical problems. So, and also is a disfigurement is one of the important major psychological part that it will be affecting psychologically, socially, and spiritually also. So we have to, whenever you do the assessment, you have to do the, if possible, you can do the individual assessment for the patient with fungating wound. And also sexuality will be affecting, maybe misconception of the disease. Maybe the partner will be thinking that the disease will be spreading to the other person also. There might be a misconception about the disease, and denial will be there. Sometimes the truth, they may not accept the truth. The tumor will be, the size will be increasing, but that the patients won't accept the truth. They may tell you, oh no, the tumor, my tumor size will be come down. That last week it was big, but now this is quite small size. That kind of things they will tell you. But the thing is, if they give this kind of information with you, you can listen their words and leave the patient there. This is not take it as a challenge. So if whenever this type of things there, you have to leave the patient there. You can listen their problems. After few that weeks, they will understand that because of that tumor size will be increasing gradually. They will come to the acceptance level. And coming to the fear, again, fear will be there. What is next? And the patient will be anxious, and finally they will be going to the depression also. If they are, if the wound size is increasing, they will always they will be thinking that what is next? Is there is any affecting other part, and that kind of things will be there. And also, if the other family, maybe relatives, will be getting these kind of maybe that their history on their own relatives were getting this type of illness there, they might be thinking that person's or always in their mind. So if sometimes they were getting maggots formation in their life, again they might be thinking like that. So am I getting that kind of things in my life also? So then shame, guilty feeling, these all the psychological impact of the patient. And coming to the social side, here family isolation. If a person, if a family, one person get this kind of illness, the family members will choose a corner side room and keep the patient there. They may not allow the patient to get that coming out of the room. They will provide all the food items and all the things inside only. They will not allow to enter the outside enter the kitchen or any other area. So that will affect the patient psychologically. And social isolation also, society, the friends and society, the neighbors or relatives are sometimes not willing to see these type of patients. Because of that, they will be feeling why they're living like this. So these may be misconception of the disease, and also social stigma, fear of contagion, effects on family, and effects on sexual relationship and marital disharmony also. Usually the people are not willing to marriage this kind of family because they might be thinking that maybe hereditary or maybe maybe that this spreading of disease from the another person also, that person also, this will be affecting the person, the patient emotionally, not the person, that the not other the family members. Because of me only my daughter is not getting marriage, that will be affecting the patient the psychologically and spiritually also. Coming to the spiritual part, they might be thinking that my interference with religious because of that, because of my sin, that God punished me like that. These kind of things will be there. So why I'm telling all those points is, so if possible, you can do the individual assessment with to the patient and the caregivers, because in front of the caregivers, they won't tell the truth. So if possible, if you do the individual assessment, they will they'll share all the problems. If they have a lot of problems there, you can help accordingly. So coming to the assessment part, always you have to do the assess the location. We can able to is there any mobility involved? We can able to cover the easily covered from the public view, because we if there is an open wound there, the public will be observed on the always observe the patient. So that will affect the patient emotionally and spiritually also, and wound appearance, surrounding skin, and potential for complication. If there is a complication, there is a chance of complication there, bleeding maybe there. So you have to prepare the patient family for that. And coming to the management part, these are the principles. Palliation of symptoms. We understand that palliative care is to our main aim of palliative care is to improve the quality of life of the patient through symptom control. So if you do the proper symptom control, definitely we can able to improve the quality of life of the patient and their family. So try to reduce the symptoms. If the patient is having pain, try to reduce pain. And if there is a odor or infection there, you can reduce odor and infection. And the exudate there, try to prevent exudate and reduce exudate. And also bleeding. You can provide holistic care. Holistic care is a total care. This patient needs 4 aspects care: physical, emotional, social, and spiritual care. Empower the patient and family in own care. So these are the principles of management. So our goal of care is, as I said earlier, to maintain quality of life through symptom control. Always give a empathetic care to the patient and family. Provide a thorough bath before dressings, if possible. If the patient is okay, you can instruct the patient to take a good bath. If they take a good bath, all necrotic tissues here, the tissues are fragile. So if they are taking good bath, all necrotic tissues will fall off. Then you can do the simple dressings like wash, clean with normal saline. Don't need that force the pressure on too much on that area to removing slough. So if they are take a good bath, easily that all necrotic tissues will fall off. And always you have to make sure that whether the patient is pain free or not. So before doing the dressings, you have to ask the patient is having pain or not. If they have pain, you can give some analgesics for that. Here also you can use normal saline for cleaning the wound. Select dressings according to the size of the wound and the exudate level. Coming to the pain management, if they have a deep pain, you have to, deep pain means nociceptive pain there. You can adjust the systemic analgesics, because, for example, if they have a morphine, 10 milligram 4-hourly morphine, they're in between. If they have developed pain, if they experience pain, they can take breakthrough dose of morphine, and again you can wait another 40 minutes. Then if they take orally, you can wait another 40 minutes. Then make sure that whether the patient is pain free, then you can do the dressings. If they have a neuropathic pain, that means superficial pain, your systemic analgesics may not help fully, that time you can apply local anesthetic agent like sensorcaine or lignocaine. Then wait for 2 to 10 minutes, and then wait for 10 minutes. Then that patient will get a local anesthetic effect. Then you can do the dressings. So coming to the malodor management, here daily cleaning and dressings. As I said earlier, stale exudate dressings have been number of days can cause malodor. If there is, so you have to train the caregivers about the importance of changing of dressings. That way we can able to prevent malodor. So here, this is the lot of necrotic tissues and anaerobic bacterial infection can cause malodor. So metronidazole is the drug of choice of controlling anaerobic bacterial infection. You can take tablet and crush it, make it a powder form and spread it on the wound. And also you can give a systematically orally also if the malodor is not controlled. And also you can do injection metronidazole irrigation too. So here we need to understand that there is a lot of pocket formation inside the wound. So your metronidazole powder may not reach inside. If you clean with metronidazole injection, they go all inside the wound. That will help to reduce the infection. And also try on course of systemic and antibiotics also. Here superficially may not have an adequate blood supply. Your antibiotics may not work well, but you can try one course of antibiotic and see whether the infection is reducing or not. And frequent changing of dressings depends upon the patient wound size and the exudate level. If the patient is having a lot of exudate, you can advise the patient to take a number of the pearls. The number of pearls is increasing. That way we can able to change the frequency of the dressings. We can reduce the frequency of changing the dressings. And here also no hydrogen peroxide and betadine. No use to here if you apply hydrogen peroxide or betadine this type of wounds, it will be irritating and distressing to the patients. It will not help to the patient wound. Day by day that wound size, that proliferation tissues will be there. So it is no use to use hydrogen peroxide and betadine here. Here also you can advise the patient to use normal saline for wound cleaning. Coming to the bleeding part, here always try to prevent bleeding. Use correct wound cleaning techniques, because the dressings are adherent to the wound. Before removing the old dressings, you have to soak the dressings well, and then try to remove the dressings. That way we can able to prevent bleeding. And also if there is a bleeding there, first you can apply local pressure. If the bleeding is not controlled, you can apply sucralfate powder. That same sucralfate tablet, crush it and make it a powder form and apply on that. Then then you can apply tranexamic acid. If the bleeding is not stopped, you can go for systemic ethamsulate. And also you can suggest palliative radiotherapy. And that is and the next important thing is dark color clothes. This is very, very important. If there is a profuse bleeding develop sometimes, so if there is a head and neck cancers there is a chance of bleeding, as maybe that tumor will be protruding the major blood vessels, and then develop a profuse bleeding, and maybe the patients died maybe because of bleeding. So we need to prepare the patient caregivers about how to manage it. So always they have to use dark color cloth for wipe out the blood, because if they wipe out the blood with the white color cloth, what happens? They will be anxious and there will be panic also. So always they can use dark color cloth. We can that way we can able to prevent that anxiety and panic level also. So coming to the role of the cancer therapy, here radiotherapy, cytotoxic chemotherapy, hormone therapy, and surgery. If the patient's health condition is okay, you can think about the debulking surgery. And if you suggest radiotherapy, chemotherapy, and hormone therapy, this will help to strengthen the size of tumor. So if the tumor size is increasing, that will be compressing the blood vessels. If that kind of that type of situation there, you can refer the oncologist and see whether the radiotherapy or chemotherapy or hormone therapy is helpful for that. If you do it, that will help to shrinken the size of tumor. That way we can able to prevent bleeding. So coming to the last slide, this is maggots that management. As we discussed it earlier, the maggots are coming from the house flies. So if the maggots formation there, you can take always try to prevent maggots formation. So we have to educate the patient and the caregivers about how to prevent maggots. So always they have to cover the wounds with proper dressings. And if the maggots there, they can use the turpentine oil. So they can then not directly pour to the wound. They can soak the turpentine oil with the gauze piece and keep close to the wound. That time that maggots will come out. So we can remove it with the help of a artery forceps. The physical removal is the only way to remove the maggots. You can remove the maggots from the wound and keep it in the hot water. Then you can discard it in the closets. So the another important message I want to convey with you all is don't follow maggots. So if you usually when we the soaked turpentine will be close to the wound, that the maggots will be coming out. So when we go with your artery forceps, they go inside. So what happened? We follow maggots. If you follow maggots, there is a chance of the break the maybe protrude the blood vessels, or maybe your injury will be happen. So don't follow maggots. When they come out, you can take it out. Otherwise, leave it there. When after you can wait another minute, then that maggots will come out. That way, that time you can remove it. Don't follow maggots. Okay. Thank you. Any questions there? You can ask.
Thank you, Sister Sheeba, for that very elaborate and detailed presentation, walking us through all the issues which a bedbound patient can face. Very practical as well. Thank you so much. So now if we can move on to questions, if participants may please feel free to use the chat box or even unmute yourself to ask the questions.
Hello, good evening.
Good
Hi,
evening,
good
sir.
evening, doctor. Please,
Yeah.
please go on.
Actually, I have a few questions based on that lecture. One of the question was like when, ma'am, when you were talking about preparing like sterile gauze pieces at home, you also mentioned about applying Vaseline and liquid paraffin to make them moist. I was having a doubt, like you apply Vaseline over the gauze and then you steam them, or you steam the gauze and then you apply the Vaseline over them and apply. I mean, you apply the Vaseline just before applying the gauze on the patient.
So usually they'll apply the gauze before they are boiling that dressing pieces. They can apply gauze piece, the Vaseline on the gauze piece, then they will sterile it. They will steam it.
Okay. And another thing is, ma'am, can you elaborate on using charcoal again? You put it just a small quantity just underneath the bed sheet after crushing them, or how's it?
No, pieces is enough.
Okay.
The thing is, charcoal dressings are available. The thing is too expensive. If the patient is not affordable, you can use a piece of maybe 1 or 2 pieces of charcoal. That is we can make it easily. That will keep in the corner of the room or under the bed of the patient. So that will help to reduce the bad smell.
Okay. And commercial preparations, ma'am, exactly what do you do when you apply directly over the wound, or you keep it nearby in the vicinity of the patient? You keep it nearby.
Nearby, not directly on the wound.
Okay.
You can keep it nearby the wound or a bed, under the bed. That will, the charcoal is the good agent for foul smell
Okay.
absorption. So that is why we keep it in the room. If the patient is having malodor in the wound, foul smell like that.
Okay. Right. Thank you.
Thank you. Sir.
Dr. Indu Prabha, please unmute yourself.
That is a wonderful presentation. Many things are new to me. I would like to know how do you apply this?
Sir, if you could repeat the
The
question, it's,
suspension that you apply
your sound is
also.
not very clear.
Yeah, that is a very good presentation. Actually, I'm a surgeon. Many things are new to me, especially this you people applying the sucralfate to the ulcer and all. How do you apply the sucral?
The same tablet we can crush it and make it a powdered form and apply on the bleeding area. Sucralfate
we have the suspension. We have the suspension only. We don't have the sucralfate tablet.
Here we are getting that sucralfate tablet. Yeah, so we usually apply the sucralfate tablet is another action. It has a sealing effect also. That
how much it costs, the sucralfate tablet?
Sorry,
How much it costs?
not sealing. That it will prevent. Sorry.
How much it costs, sucralfate tablet?
So let me check it and let you know, sir. I don't know.
Okay.
Dr. Deepak, do you have any idea about that?
No, sir, I am also not very much aware of the cost of it. We'll definitely check on it and let you know about it.
Okay, thank you.
So we have some questions on the chat box, Sister Sheeba. So one is, can dressing of wounds be done with sterile gloves, or is clean gloves okay to use?
Clean gloves is enough. This is a clean wound. This is not a surgical wound. This is a clean wound. You can use clean gloves. So if the clean gloves is not available, you can wash your hands with soap and water. The help of artery forceps. Sometimes we are not using gloves also. No need to touch the wound, no, if you have a artery forceps. So, but you can wear clean gloves.
So another question is, when should we cover the ulcer and when can we keep it open? Are there situations where we leave the ulcers open? If so, when can we decide when to leave it open or keep it closed?
No, once the crust formation there, then you can that open. Otherwise, you can close it always. So the thing is, if the house flies touch the wound, maggots formation. So once the crust formation there is no chance to develop maggots formation. So then you can leave it open. Otherwise, you can close it. Close the wound always.
Thank you, Sister Ji. So one of the questions we have from Dr. Jason is, can ketamine be used sublingually before dressing to reduce pain?
Sir, we are not using ketamine here. If the patient is having bone pain like that, incident pain there, you can use in ketamine. But for wound management, we are not using ketamine. You can either adjust systemic analgesis. You can give breakthrough dose of morphine or whatever medications, or you can use local anesthetic agent like lignocaine or bupivacaine.
Yes. So is there any concern about antibiotic resistance using metronidazole topically? Have we seen any such instance in patients, Sister Ji?
Yes.
So usually no.
Yes.
Metronidazole is something which we have been using left and right, and it's an extremely effective drug to use locally. Apart from this, when we see that the wound healing is not becoming proper, at such instances, we do take a pus swab or a local swab and we send it for culture, and then we may need to start antibiotics accordingly. Apart from that, we have not seen any instances where, using it topically has caused resistance as such.
Yes, and also if the malodor is not controlled, you can then you can give oral medication, oral metronidazole also. The thing is, one of the major side effect is nausea, vomiting. So you initially 3 times a day, then after 2 weeks you can taper it. 1 BD, then 1 OD, like that. But superficially, it will be very helpful, as Dr. Deepak said.
So we have a question from Dr. Jennifer. She's asking 1 tablespoon of salt. Is it used for 500 ml of water?
1 teaspoon is enough. 1 teaspoon, not tablespoon. 1 teaspoon full of salt is 500 ml of water.
Okay, thank you, Sister Ji. So there is a question
Sorry,
from Dr. Arnab.
I wanted to ask, is it level teaspoon? Do you level it, or do you take a whole scoop full of it?
Yeah,
So I will show you a video on that, ma'am. You will get a good idea about that.
Okay, thank you. And also I had heard, I worked in a peripheral hospital where bed sores were being dressed with pure honey. And it promoted granulation. I just wanted to know if you've heard anything about it, or do you use it?
Yes, ma'am. I don't have any experience, but people coming out with here is a training institution also. Here we have usually get a lot of trainees from the different areas. They are using the honey and sugar paste and all. So, but we don't have any experience, and also have a good evidence also. That honey is the good medication for preventing bacterial growth and all. So, but we don't use any honey dressings and sugar paste dressings.
Yeah. Thank you.
Okay, thank you, ma'am. So, can we move on to the case presentation, Dr. Deepak?
Yes, sure. We can move on to the case presentation, and the remaining discussions we can take it up after the case presentation. Dr. Marina?
Yes, sir. Shall I start?
Yes, doctor.
Yes, please, doctor.
Yes. Good evening to everyone. I'm Dr. Marina Fernandez. I work as a medical officer in the Directorate of Health Services in Goa. I'll be presenting a case on chronic, it's a large chronic non-healing ulcer of the left leg in a 54-year-old male. Next, please. The history of the presenting complaints is there was an ulcer in the left leg since the last 1 year. It started as a small sized wound, gradually increasing to the present size. There was a foul smelling discharge from the wound also. History of the illness. There's history of developing an ulcer on the right foot initially, followed by one on the left foot while at work 5 years ago. The ulcers were initially very small size, but they gradually increased to the present size to involve the entire foot and the lower end of the leg. It was due to improper care and poor hygiene. The ulcers had foul-smelling discharge and on occasions were also infested with maggots. About a year ago, he was referred to a tertiary care center for desloughing of the wounds. He was admitted there for approximately 1.5 months. Skin grafting was done to cover the ulcers. The graft of the right leg picked up well and it healed. The left ulcer graft was, however, unhealthy and sloughed off. He followed up with us for regular dressings after that for the left foot for the last 1 year. Next, please. On examination, the ulcer on the left, there were 2 ulcers on the left leg, one over the dorsum and one over the lower end of the leg over the lateral medialis, measuring 8x5 and 10x4 centimeters respectively. Margins were irregular. The edge was indurated, non-tender. There was foul-smelling serosanguinous discharge with slough over the floor of the ulcers. Underlying tendons were visible on the dorsum of the left foot. There was induration, scarring, and pigmentation seen over the surrounding areas of the ulcer. He was an average heighted, thinly built man, pale. There was icterus. There was pedal edema of both the feet up to the ankles. Peripheral pulses were well felt in both the feet. Motor and sensory functions of both lower limbs were intact. No regional lymphadenopathy. Next, please. Routine investigations were mostly all normal. His culture sensitivity for the pus was sent, which was sensitive to most of the commonly used antibiotics. It was negative for AFB. X-ray was normal. Chest X-ray was also normal. Good hygiene was advocated. He was advised rest and elevation of the limbs, daily dressing of the wound with normal saline, povidone iodine, and paraffin gauze. Broad spectrum antibiotics were given while he was at the hospital and following discharge, along with anti-inflammatories. As of now, he only comes for regular dressings. Next, please. Psychological aspects. He's a 54-year-old man belonging to the lower socioeconomic group, living alone with no source of income. The food is provided to him by his neighbors and daughter. He has one daughter who is married and who has recently delivered preterm twins. There's no access to proper hygiene in the one-room hut that he lives in. He's unable to go to work due to the long-standing foul-smelling ulcers, and who resorts to alcohol at times to forget the pain. Next, please. Medications. He's only doing daily dressings with us. Iron and vitamin supplements have been given to him. Antibiotics were given initially when he had the infection. As of now, he's off the antibiotics. Main concern is he's a single 54-year-old man, no source of income. He has to rely on food given by his neighbors and daughter. He wants to resume work, but he cannot because of his ulcers. He's afraid of the length of the time taken for the wounds to heal and the increasing size of the ulcers. The daily commute from his hut to the health center where we do his dressing is a walking distance of 3 to 4 kilometers for him, which is painful and exhausting. There's no financial support as he is a migrant and has no valid ID cards or documents with him. Next, please. Summary. He's a widowed 54-year-old man with large chronic non-healing ulcers of the left leg. Thank you. Discussion points. What can be done to hasten the healing of the ulcers? Should he be referred to the tertiary care center once more for further management, but will be bearing the cost? Patient is unwilling to go through another surgery for the foot. How do we counsel him for the same? Do we deal with the patient resorting? How do we deal with the patient resorting to alcohol consumption on and off? How do we motivate and counsel him to come daily for his dressings? Thank you.
Thank you, Dr. Marina, for that
Yes.
presentation.
Yes.
So, do you want to start off the discussion? What can be done to hasten the
Yes.
healing of the ulcer, according to you?
Yeah, I think he should only come for regular dressings because we have tried every other possible means. He is not very regular with us. We have tried motivating him, although he says he wants the wounds to heal. He's still not making it. He's not still coming for a daily dressing. So if we can motivate him for that, maybe it could help. Or if we could provide him some institutional care.
Yes. So there are some questions on this, follow-up questions to your presentation. Like, is there any secondary cause which can cause the?
No,
Yeah.
he started with the ulcers following injury, but we have really no idea why the wounds are not healing because all his reports are normal. His Doppler is normal. His peripheral pulsations are intact. He's sensitive to most of the antibiotics which are available with us. He has even been treated for a skin graft, but somehow the wounds, I think it's because of poor hygiene and he's not regular.
Yeah, the fact that there were maggots definitely points that there has been an issue with the hygiene. So one thing which we have seen very often is, especially in people, patients with low socioeconomic strata, is that we give them all the instructions. However, once they go back home, what happens is a different story. And of course, there are a lot of psychosocial aspects also which plays in it. That one is the patient himself may want to do things, but the family may already have to take care of other things. So they get burdened doing something for the patient on a daily basis. So because of that, the patient ends up not asking also that the sort of care which he really needs. So there are aspects which play a role, which is other than just, the physical aspects to the patient.
Right. There was a question on the chat whether it's a neglected wound. There was pain. He does complain of pain on and off, but Hansen's has been ruled out. His biopsy was done. It has been ruled out already.
Okay. Okay, doctor. So I think that probably we may have to look again if there is any investigation which was missed, or you know, was he on a borderline? Was he pre-diabetic? Something like that. Is there any clue which we are
No,
missing
his
in this
sugars were
case?
normal. We are planning to refer him again to the tertiary care center, but we are looking out for somebody to sponsor his treatment over there.
Okay,
So if
you
that
had
can be
mentioned
done.
something about a skin
Yes, he
grafting
was
as well.
admitted last year, about a year ago, somewhere in the month of March, for de-sloughing because he had a very severe maggot infestation with a lot of slough. So he was kept back over there for almost a month and a half. His wounds were much better there. Skin grafting was done, but then only one graft picked up of the right leg. The left leg de-sloughed again.
Okay. And did the biopsy report reveal anything in specific?
Nothing. No, it was nothing. There was nothing there.
Was there any instance of, you know, the patient having some psychological issue because of which he was hurting himself or something like that?
It's nothing of that sort. Basically, he lives alone, lower socioeconomic group. He's a migrant daily wage worker. So his major problem actually is coming for a routine daily dressing, because if he says he cannot come for a daily dressing, he misses out on his daily wage. So
Yeah.
there is a little bit of a problem. And hygiene, of course, yes.
So this is one place where I would like to interject and say that the role of volunteers, you know, when somebody is in this kind of a situation, and if you're doing something for the patient, to have a continuum of care, volunteers can play a very important role. Somebody who can visit the patient on a daily basis, at least once, you know, if not twice for the dressing, at least once, to ensure that the dressing was done, that he also feels that, you know, somebody is coming, is concerned about his health, and who is willing to take care, at least up to whatever extent possible. So these are steps which is, you know, doesn't fall under the purview of pure medical management, but something else, the social aspects can be taken care of little better. So through this way, we can even source some funding, you know, to take care of the medications, of the dressing and things like that.
Right.
So yeah, so moving on to the next question, should he be referred to a tertiary care center once you're more for further management, but who will bear the cost? So we just looked
we
at
are
it
trying
that,
to we are trying to refer him again, looking out for some donors who can help with his treatment.
so if anyone could give an answer or give ideas to how to go about the third point, which is, if the patient is unwilling to go for the foot surgery, how do we counsel him for the same? And do we really need to go for a foot surgery? That is another question which we need to ask. So meanwhile, we have some inputs. Anemia and HIV are often missed in men as a cause of neuropathy. So was any HIV investigation?
Yeah, his HIV test was negative. His zero results were all negative. Hepatitis B HIV was done. It was negative. Pre-operatively, it was done. He was anemic. He was given iron. He was in fact transfused with 1 pint of packed cells during the surgery.
Doctor, do you have in mind what kind of foot surgery? Is it again going for a grafting?
Yeah, we are not sure. So right now, his wound is clean, but it is not healing. It's just not covering up. We have tried giving him the mega heal, as Madam mentioned today, but it's not helping him. The wound is just not getting covered up. In fact, it's only increasing in size.
Okay. Was an arterial Doppler or something like that done?
Yes, his Doppler was normal. There was no insufficiency.
Okay. So Dr. Shalin has a question that what precisely is his job? We said that he's a daily wage worker.
He's a daily wage worker.
Okay, so probably it has to do with something about lifting weights.
Absolutely, yes. Yes.
Yeah.
So his hygiene is a major issue. Since it's the foot, there's really no way to keep it clean and dry. So there are various instances where he has come with absolutely soiled dressings. So the only way out actually would have been to institutionalize him, but it's very difficult in the given circumstances. He's also not willing to stay in any place.
Yeah. So this is something which we have seen commonly. that daily wage workers or coolie workers, they are people who beyond a point, beyond a few days, maybe they just can't afford to stay at home, they just have to start stepping out. There is no other way for it. And usually they wear chappals. And it's not like, in some of the countries do have good laws where wage workers are well protected. They're giving helmets, boots, things like that. So even if we are giving him a proper dressing, if he had boots, probably it would be of better help to ensure that the wound doesn't get soiled. But in Indian circumstances, I'm not sure practically how much it is possible. So, so looking at the next question, how do we deal with the patient resorting to alcohol consumption on and off? So this is again another area because many a times which we have seen that the small amount of money which they earn, it goes in for aspects like drugs and alcohol, very commonly seen. And this requires a lot of hand holding. From a medical perspective, we can do only so much. But this is a good case where, the all four dimensions of palliative care have to come together. Exactly. So the social worker has to be brought in on this. The volunteer has to be brought in on this. And then we have to
we have tried putting him in, we have an NGO here, it's called as a Street Providence. We have tried keeping him there, but he's not willing to stay in that place. He wishes to stay in his own home. So it becomes a bit of a dicey situation for us because he is not willing himself.
Okay. So have you explored the possibility of connecting volunteers to this patient?
Yes, we have tried. We have tried to put him in touch with the NGO that's called as a Street Providence, which helps it basically helps the homeless, but he could have been also helped with them. They have an in-house attendant who does these daily dressings. They provide food. They also provide the medications which are required. Okay. And we ourselves go over there once every fortnight to visit the people admitted there.
Okay. So they have started the process of visiting this patient?
Yes, this patient is currently in his home. We tried to keep him there. He stayed there for a day or two and then moved out again.
Yeah. So by volunteers, what I exactly meant is somebody in the local area, where he stays, somebody over there on the ground, who stays probably within reaching distance of his house. So that is one thing which we very commonly do in our setting over here as far as possible. Whenever we need to do something like this, one is doctor's house visits or even nurses' home visits whenever doctor's house visit is not possible. But I understand that going daily will be obviously difficult for the medical team. So that is where some volunteer whom we can, train probably in a very basic way to ensure that he is able to help out the person. So this can even be some college groups, there are one is NGOs definitely, which you are already exploring. Other is college groups, students, people like that. Then of course there are many people who are retired. After retired, they're looking to get somehow involved with the community. They're looking to get active again with some tasks. So having a good volunteer base is always helping. Will help, in dealing with various situations. Even later on. So looking at the chats again, yeah, as Dr. Manjari says, all questions and problems are interconnected. Definitely it is interconnected. It is not just about how good we are as a clinician or what all we do medically. There is much more to this than what meets the eye. Dr. Jyoti is asking if we can see the initial local examination. If we can just put on the slide where the local examination is. Yeah, so it's a left leg ulcer over dorsum and lateral aspect of the lower end of the leg over the lateral malleolus. 8 into 5 centimeters and 10 into 4 centimeters, irregular, indurated and non-tender. Foul smell is there, slough is there. And it looks like it's a grade 4 ulcer. if we could also look at the slide showing the current medication. So he's on iron and vitamin supplements, and antibiotics were given initially for the infection. So that's it about this. So coming back to this, yeah, Dr. Shalini is saying bad footwear. Yeah, we already discussed this point. Definitely bad footwear is something which is something causing the delay of healing, or probably it is not allowing the healing. Dr. Arnab, coming back to your question about use of tetracyclines and phenytoin, yeah, we are aware that in various centers, they do use drugs to try hasten the process of healing. But one thing is, evidence of this is pretty scanty, and we don't use this as far as our center is concerned. So also that we have learned from experience that many times fungating wounds or ulceroproliferative wounds are not, they won't heal. So the goal of care in such patients is not healing of the ulcer. It is just to keep it as a clean wound, to ensure that there is no foul smell which is occurring, and to ensure that it doesn't get maggot infested, and pain free, of course. So these are the goals of care for such patients. Whenever it is due to, there is a secondary cause like diabetes, varicosities, etc. Obviously, we try putting that also under control. For pain, good pain management is done. So your second question was about exactly how to use local anesthetic over there. So we use plain lignocaine. Okay, we use plain lignocaine in a dose of 3 to 5 milligram per kg of body weight, and we soak a gauze in it and we put it over the area which needs to be dressed. So in 5 to 10 minutes, this area becomes pain free, and then you can proceed with the dressing. So the reason why we have to look into 3 to 5 milligram per kg is there will be small blood vessels over here, capillaries, through which this can get absorbed systemically as well. That's why we have to look at the dose and then do the gauze based pain management before doing the dressing. So yeah, the edge, Dr. Jyoti is saying that the edges being irregular, non-healing nature slough, I might suggest repeat biopsy to rule out malignancy, as at times biopsy is done necrotic slough, which may be inconclusive. True, true, Dr. Jyoti. If we have, see, one of the things is we always have to look into the economic aspects. One thing is, once a proper biopsy has been done, usually I think it's done from 3 sides. I'm not clear, but I think 3 sides from the edges it is taken. Once that is done, and if it is ruled out, then we consider it for the word, because this is not a person who can afford, and we don't want to put the patient through that, financial toxicity as well. So this is this takes us back to one of the earlier questions, that why don't we usually prescribe antibiotics only after doing a pus culture. But again, we are seeing that majority of such cases who have non-healing ulcers, many of them, I won't say majority, many of them look
Dr. Deepak? Dr. Deepak, your voice is breaking.
Sorry, can you hear me?
Yeah.
Okay, sorry. Can you hear me now?
Yes, please go ahead.
Yeah, sorry. Where did I leave off last? I don't know where it got disconnected.
It's okay. It was just a few seconds, I believe. You can continue.
Okay, fine. So I was saying that always financial toxicity is something which we have to be careful of. I would like to remind all of you that in the year 2017 or 18, there was a study which told that in India, 55 million people were pushed to below poverty level because of out-of-pocket expenditure. And as palliative care, principles, one of the major things which we try doing always is ethical practice of medicine, which also means that we don't put the patient through unnecessary investigations. So we have seen through practical experience that using a simple Metrogel powdered dressing with Vaseline takes care of the wound over a certain period of time. and it is very easily managed at home itself. So these are certain things which we should keep in mind before we, before we suggest any more investigations to the.
Dr. Deepak, I think you got muted.
Yeah, sorry about that. So I think today's discussion was pretty, it was a classical case where palliative care principles play a huge role in addressing and how the importance of addressing all 4 dimensions of it. So if there is any closing remark which Sister Sheeba would like to put on regarding these aspects before we close.
No, Dr. Deepak, you already covered all the aspects.
Okay. So I think thank you, Sister Sheeba, for that really elaborate, detailed presentation. Even the case selection was really good. This showed us the importance of various aspects, which is not just medical. And it was a timely reminder that how we should look at the patient as a whole. The concept of total care, which means not just medical or physical aspects, but going to social, psychosocial, emotional, and financial aspects as well. So on that note, let's call it an evening. Thank you so much, Sister Sheeba, for spending time out of your busy schedule for us. Sri Priya for hosting the session, and all the participants who made such a lively discussion possible. For the closing, over to you, Sri Priya.
Thank you, Dr. Deepak. Thank you so much. Thank you, every participant. I believe that today's session was eye-opener for those who I think definitely it was a session on a topic which was unexplored or less explored during the practices. So thank you, Sister Sheeba, for taking us through that. And Dr. Deepak, I do know that you are held up and still you managed to join us for facilitating. Thank you so much for that. And with that note, this is Sri Priya along with Sister Sheeba and Dr. Deepak Sudhakaran signing off from the Tips Eco Hub. See you in the next session with another very interesting topic. Till then, everyone, stay safe, be happy. Take care. Bye-bye.